So good afternoon and welcome back to Penn. This is the session on healthcare reform. My name is Kristen Madison. I joined the Penn faculty in 2001, and ever since I started here, I've taught healthcare law. That is my primary research area. I'm also an economist. I'm interested in both the economic and the legal side of healthcare, as well as healthcare delivery in general. I'm going to give the introduction to healthcare reform today, and then I will defer to my colleague, Tom Baker, who is Penn's and I think the country's and maybe even the world's leading expert on health insurance, or insurance generally. He teaches insurance and torts, and he also teaches at Wharton in risk management. And so Tom will be talking about the health insurance exchanges and some of the other issues that are integral to healthcare reform. So let me just start by saying that we are in an era of tremendous change for healthcare in this country in a lot of different ways. In the last decade, there's been a renewed focus on healthcare quality and safety. There's been tremendous consolidation of hospitals and also of insurers. There's been a significant expansion of access in healthcare. In 2003, Medicare Part D was created, greatly expanding access of the elderly to pharmaceuticals. Last year, in 2009, we saw even more reform. As part of the stimulus bill, there was something passed called the High Tech Act, which was the Health Information Technology for Economic and Clinical Health Act. And what Congress did in that act was appropriate many billions of dollars to foster the growth of electronic health records in the healthcare industry. They're trying to incentivize meaningful use of those records, which I think will have tremendous potential to revolutionize healthcare delivery in this country. But I think it's really this year where that revolution really became much more likely, when in March Congress passed and the President signed the Patient Protection and Affordable Care Act. This bill does a lot of different things, and no doubt you've heard about many of them. You've probably heard about the provision that says that parents can add their dependents under age of 26 to a group plan. You may have heard that there are going to be high-risk pools created that will allow people who are already sick to get more affordable coverage. You may have heard about these things mostly because they are some of the things that are happening right away, whereas many other provisions in the bill will take longer to implement. There are probably a lot of other things that you may not have heard about if you haven't been sort of watching everything that comes across the news. And so my task here in this introduction is to give you a little bit about sort of what the core of the bill is about, and then Tom will expand upon that, and then talk a little bit about some of the other provisions in the bill that are less well known. So the single most important function of the healthcare reform bill is to expand access to insurance. The projections are that it will increase the number of insured Americans by about 32 million people in the upcoming years, in the hope that more insurance will lead to more access to care. This expansion happens through a lot of different kinds of mechanisms. First of all, the requirement that individuals have insurance or pay a tax penalty if they don't. The creation of state-based exchanges where individuals can purchase their plan, and where also small businesses will be able to purchase plans for their employees. There will be subsidies to individuals who have incomes of up to 4 times the poverty line to enable them to actually purchase plans through these exchanges. And there will be regulations on the structure of the plans that are sold, what kinds of things that they will include. There are limitations on the criteria that can be used to set rates for these plans. One of the major ones is that you cannot exclude individuals due to their pre-existing illnesses. There are fees going to be imposed on certain employers that don't offer coverage to their employees, and tax credits for small employers that do offer coverage to their employees. There will be a major expansion of Medicaid. This is a major transformation of a program that has long been categorical in nature, one that serve very distinct populations, for example, children or pregnant women or the disabled, to one that essentially will serve all poor individuals. So this is a major change. The bill will close the Medicare Part D donut hole so that people have more coverage in getting pharmaceuticals. And it will also increase funding for community health centers. So there are many, many different provisions that combined and aggregate will help to increase access to health care. These aren't the only changes that are in the bill. Those are, I think, the primary ones, the ones at the core of the bill. But the healthcare reform bill was really an opportunity for many reforms that have long been discussed within the legislator community, the policymaker community, and also healthcare communities in general. It was an opportunity for them to be implemented. So many of these sort of ideas that have been floating around for a while were included in the bill, but some of them were in watered-down forms. For example, medical malpractice reform has been discussed for a very long time. Physicians in particular have long lobbied for caps on damages from tort lawsuits, and they did not get the caps in this bill. Instead, what we got was demonstration grants for states to develop alternative mechanisms to address injuries in health care. And so this is not what some people have lobbied for. Another institution that was created, but in a watered-down form, was the Patient-Centered Outcomes Research Institute, which has the important function of looking at effectiveness of medical treatment. But the findings of this effectiveness research that's going to happen are not supposed to be used to deny coverage and is not going to be focused on cost. And so that is watered down relative to the vision that some people have of an institute that would consider not only what the effects of new forms and existing forms of treatment, for that matter, on health, but also how costly they are, to allow us to compare these things. One example of a new provision in the bill that has been discussed for a long time and has been in bill form for a long time but not passed until the statute actually was enacted was a mandatory provision for disclosure of the financial relationships between doctors and pharmaceutical companies and medical device companies, so that many physicians currently are paid by drug companies or by device companies and for lots of different things and in lots of different forms. So there have been some institutions that have proactively begun to disclose. So, for example, you can go to the Penn website and you can find out information about what Penn's doctors' relationships are with some of these companies. But you can't generally, and what this bill mandates is disclosure generally across the country of these relationships. Another set of long discussed reforms is various kinds of requirements on not-for-profit hospitals. Among other things, they limit the charges that they can place on uninsured patients who are in need of financial assistance. There is a creation of a new national insurance program for long-term care that basically provides cash financial support for people with functional limitations, and it helps them remain in the community without first requiring them to become poor enough to qualify for Medicaid, which is the default now. There's also a series of provisions that are directed at public health. So, for example, the elimination of Medicare coinsurance for certain kinds of preventive services. There's a requirement that chain restaurants disclose nutritional content on their menus. And so for some areas of this country, this is a new provision, which means that a lot more information will be available about things like calories. But for other areas of the country, this may mean less information is available because of a number of states and local areas, including Philadelphia, have created their own mandates, which will now be preempted. Another thing that the bill does is raise the ceiling on the level of financial incentives that employers are able to use to encourage healthy behaviors. So things like you will get, waive a co-payment, for example, if you can go and show that your cholesterol levels are decreasing. Basically, there are provisions in this reform that encourages employers to engage in those kinds of programs. There are also a series of changes to Medicare, which I will talk about in a few minutes after Tom has talked a little bit about the exchanges, because I think those changes in Medicare could have very long-lasting effects on care that is delivered. So, Tom?
Oh, good. Thanks for coming. And I've been here at Penn for just 2 years, and I'm really delighted to be here. And this is my first chance to talk to the alumni, and I don't yet have a lot of alumni who've been my students, but hopefully over the years that'll change. What I'm going to talk about are the insurance market aspects of the health reform bill. Most of the broad brush, which Kristen has already talked about. And at the kind of biggest picture level, what I would say about the insurance market regulations is that we're in the process of a shift of authority from states to the federal government over the regulation of the healthcare market. That there was a statute passed called ERISA, which people may have heard about, which had the impact of basically deregulating healthcare in the employment benefit context. In which eliminated states' substantive regulation of health insurance, and that these aspects here that I'm going to talk about in a minute, I think of those as the state, as the federal government kind of stepping in and providing a sort of content, a substantive regulation of healthcare benefits that replaces what states have in many cases had, but was preempted by ERISA. And so the basic and these. As people have probably heard about, the different aspects of the bill come into place come into action in different times. The things that I'm going to talk about today, we can understand them as coming into effect 2014, unless I describe otherwise. And 2014 is a nifty year for a lot of reasons. One of which is it's after the next election, and maybe another Supreme Court justice besides my friend Elena Kagan will be appointed, and all kinds of good things will happen before then, which we'll go to some of the constitutional challenges that we'll talk about at the end if we have time. It's not clear to me. Just see if I can. All right. Anyway, I can't. This is working. So there's a new concept in the bill about what's the actuarial value of covered benefits, and what that means is that the total cost of the benefits provided by the plan must be shared between the plan and the participants on average, so that at least 60% of those costs are covered by the plan. And there's also going to be a cap on the annual spending, and that cap will be a sliding scale that will depend on income. And the cap is set to match what you can do for healthcare savings accounts, so that people will be able to, in the employment context, be able to have pre-tax sheltered healthcare savings accounts that will allow them to pay for the first level of care, and then their plan will pay for the rest. There's no cost sharing for preventive services, no lifetime cap starting this year, no annual cap starting in 2014. The dependent care coverage that people have mentioned comes into effect in September, but if you are part of a employment-based group in which the plan year begins before September, you are out of luck. And so I am part of the Penn group, and I have a son graduating from Vassar College, and the Penn plan year begins July 1, so I will be picking him up under the Penn plan next year, not this year. So that's another sort of fine print way in which this thing rolls out a little bit slowly. Rescission only for fraud, that's in other words, they can only deny coverage for you if you have committed fraud, and what we'll see in a minute is that the things that you will be able to defraud them about are so few that there will not be a lot of rescission anyway. No pre-existing condition exclusions. This is a major change, and it kicks in this year for kids. Kicks in 2014 for everyone else. And the reason it kicks in 2014 for everyone else is it's not going to be mandatory that you have insurance until 2014. And of course, the elimination of a pre-existing condition exclusion is a problem, because then there's a situation where someone might choose not to buy insurance until they get sick, and that's known as adverse selection, and that could lead to the really inability to maintain an insurance market. So you can't have a elimination of pre-existing condition exclusions unless you require people to have insurance. And actually, this little part is a potentially crucial part to the response to the constitutional challenges I'll talk about in a minute. You can't have waiting periods that are longer than 90 days. And there's some other provisions. And grandfather plans, meaning plans that are already in existence, are partly exempt from some of these, but not from the most important ones. So again, at the very big picture, think about it that the Department of Health and Human Services is going to be deciding through a regulatory process of what health care plans are going to contain, and that's a major shift. All right, some other insurance market reforms. There are some reporting requirements that will be for the first time, and these are innovations in the insurance field generally. In other words, this kind of that they're going to have to report their medical loss ratio. In other words, how much of the dollars that they spend are for care, and how much of them are for overhead and other things. And if the dollars spent on other things, not care, are above a certain threshold, there will have to be rebates. And that is a big change. There will be oversight of premium increases. The experience with automobile insurance, and workers' compensation insurance, which are the kind of insurance kinds of insurance that are now most heavily rate regulated by states, are not promising in terms of this actually being good from a public policy perspective. That states that have tended to be kind of tough on automobile insurance regulation have had problems keeping insurance companies in the market. And so, we'll see that, this is a little bit of a step away from competition as a way of regulating the health insurance market, and we'll see, whether that works. There's a variety of sort of fine print things. These, I call them back office standards in reporting. There's a whole bunch of things that have to be regularized, standardized in the health insurance industry, that are designed to make it easier for people to switch plans, and that are designed to make it easier to compare plans, and that are going to be, if done well, will actually, I think, promote competition in the market. So even though we're maybe stepping back on having competition by regulating premium increases, we are going to be setting up a sort of back office standards that will make it easier for people to compare. Very important, guaranteed issue, that they can't turn you down for anything starting in 2014. And when they decide what they're going to be charging you, they can only consider 4 things to set. And right now there is really essentially no limit on no limit other than the market and cost and information on what an insurance company can use in order to decide what to charge. And now they're only going to be able to look at your age, at your region, at how many people are in your family. It's going to be interesting if they get into what is a family. That'll be exciting and disturbing or not, depending on your perspective. And they're allowed to charge you up to 1.5 times or anyone else because you use tobacco, which is a kind of interesting, strange bedfellows thing here. I could imagine a lot of other things other than tobacco that could have been in the list of 4, but I think this is the public health group lining up with the insurance industry, which wants to have as much freedom to risk rate as possible. And so the total difference between the price charged for the lowest risk person, and the price charged to the highest risk person is 3 to 1, which is a very narrow range compared to what's possible today. If you were to look at just price based on age, you would see variations in the more like 1 to 9. So very substantial restriction on risk rating. And a possibility of what I am calling product-based risk classification. In other words, if it turns out that I can't charge you, you're a low-risk person, and I would really like to get you in my plan, but I can't offer you your truly low-risk price with this plan. So what I think that people are going to start doing is trying to invent plans that appeal disproportionately to low-risk people, so that there will, I think, in fact, be more risk stratification, risk classification through product design than is allowed. And that is going to be a kind of cat and mouse game between the insurance industry and the regulators to some degree. And I taught risk management this semester at Wharton, and I, sort of not kiddingly told these students that some of them are going to go work for consulting firms, or what their job is going to do is going to be invent ways, new designs of health insurance that are going to appeal to low-risk people. Then a final issue that got a lot of press at the end is abortion coverage, and there's not allowed to be any subsidies for abortion coverage, and there's some kind of complicated details to the abortion coverage topic that I'm not going to talk about, mostly because I don't really understand them. All right, so as I said, we're continuing in a trend away from state regulation of health insurance towards federal regulation of health insurance, but the statute leaves a substantial amount of authority with states. And it's not clear whether that's a long-term plan or whether we're in a transition where this will gradually be taken away from the states. But the states are going to have these American Health Benefit Exchanges. That's HHBE. That's the individual exchange that you might have been hearing about. And then SHOP, which is the small business exchange. And the states have the option to run separate exchanges for small businesses, and small businesses defined as up to 100 employees, which is a little bit of an interesting definition, because you only have to offer health insurance as an employer if you have 50 employees. So there's going to be some, so people who are in the 50 to 100 employee business, which is going to be plenty of law firms, and if you think about it, a lot of law firms have got 50 to 100 employees, are going, consulting firms, things like that, so they may be going, looking at these shops, and the states can run them either separately or together, and they're, this is a new thing. This is going to be, nobody really knows what they're going to look like. My friend and colleague Joel Ario, who's the Pennsylvania Insurance Commissioner, is spending a lot of his time these days thinking about what they're going to look like. The idea is that this will be web-based, that you'll be able to go onto a website, you'll be able to compare all these plans. How people are, how many people here have ever gone to the Medicare Part D website that allows you to compare Medicare? Yeah, and so think that on steroids. Because that's just about your prescription benefits. Well, now you're going to have to compare, I don't know how many different. It could be 50, it could be 100. And one of the things, an area of my research at the moment is looking at what can be learned from the research in behavioral economics or behavioral decision research on how people make complicated choices, to help think about ways that we can design these websites so that people can make, what would be good choices. A state is free to further limit risk rating. So, for instance, New York has guaranteed issue community rating, meaning everyone must sign up. Everyone can sign up, and everyone gets the same price for some kinds of health care plans, and that is free. So that a state can limit risk rating even further. And so I assume that New York will continue to require community rating for at least some things. There'll be pilot programs for wellness rebates. That's going to be very interesting. In the employment-based plan area, as Kristen said, that employers are free to give rebates and other things up to half of your premiums back. It can give you up to half of your premiums back in return for participating in wellness plans, which is a much larger amount than has been in the past. In the individual market, there's going to just be there are going to be some pilot plans. I think they've authorized up to 10 states to see how that will work in the individual market. That the concern about these wellness rebates is that if we want to limit risk classification and limit the difference between what low risk and high risk people pay, that a wellness wellness participation discount could be a way of sort of favoring low risk people as compared to high risk people, because many wellness type programs you can't participate in if you're not well. And of course, it's people who are not as well or have chronic conditions that are the more high risk. So that's the concern about that. States are authorized to create multi-state compacts, which will be a new thing, where the idea will be that if you get approved in Pennsylvania to sell health insurance, that you'll be able to sell insurance in every other state that's in the compact. If that works, that will be a first in the U.S. and will be interesting to work. So that's a state. All right. So my personal view about the healthcare reform is that we've now we may have managed to get everyone under the health insurance umbrella, but that was the easy problem. The hard problem is healthcare costs, and this is my favorite cartoon of the period, and here's the Easter bunny. The image here is that it's not accidental that this is the Easter egg chasing the little kids, because of course it's our kids who are going to be bearing the costs of this. So I just got a few little factoids about healthcare costs. So I'm sure you're all familiar with this kind of thing, but this shows the per capita as healthcare costs as a share of domestic product, 1960 to 2008. We're cruising right up. The United States is the top line on here. We've got on the left is average spending on healthcare per capita, and then the right, healthcare expenditures as a portion of GDP. We're leading the cap, and part of that's because we're a rich country, and healthcare is the kind of good that the more money you have, the more you want. But if you were to plot, but we're leading the pack in that regard. It's not just that we're rich. This slide is the most worrisome one for me. It shows the relationship between wages, inflation, and health insurance premiums. And what this means is that as a time when wages are basically barely keeping up with inflation, and by the way, they're not keeping up with inflation all across the income spread. They're more doing that at the middle and upper than at the bottom. At the time when wages are barely keeping up with inflation, that health insurance premiums are going up, which means that a larger percentage of people's compensation is going to pay for health care, which of course is in a way common sense when health care is becoming a larger and larger portion of our economy. It makes sense that more and more of people's money goes to pay for it, but that's not the only thing that goes into our utility function to think about it from an economic perspective, so we have to wonder whether that's really a good idea. All right, so here's some, this is not a list that I've invented, but here's a bunch of reasons why things are going up. That, one reason that things are expensive in healthcare in relative to soap is that people pay for soap. They don't pay for healthcare at a marginal level, so we don't shop on the basis of, related to that providers, people who provide health care know that they're not being paid by the people who come to see them, and so there's an agency cost, maybe some over-prescribing, maybe less concern about cost than there would be. I mean, lawyers, that in the legal world, there are, of course, insurance companies, liability insurance companies, who pay defense lawyers, and their defendants are not paid for by the insurance companies. But of course, as I'm sure you're well aware, either through personal experience or through colleagues or friends, that these liability insurance companies are just crazy to manage the costs in a really very aggressive way, and we have not seen that in the health insurance area. Lots of things there's new and better technology, better drugs. They're expensive. They're good for us. We want them, so that leads to more expense. More people, as a consequence of that, you survive longer. There's more expensive, babies that would have died, 100 years ago live. Arguably, there's not enough prevention. The more we're changing our ideas about what it means to be healthy. But so all of these things are things that lead to increasing healthcare costs. And the question really is, where is the 2010 health reform on these? And the answer is nowhere. So round 2 of health reform is going to have to bend this cost curve, or else, our grandkids and our kids are going to be rolled over by the healthcare costs egg that was tossed at the White House Easter egg roll this year.
So I think one of the themes that has come out of our comments is that one of the things the healthcare reform bill does is it shifts responsibility between the federal government and the state government in a lot of different ways. So Tom pointed out that the federal government has sort of taken over a lot more regulation that was traditionally the province of state governments. At the same time, states will continue to be active and will be creating new institutions within states to handle health insurance. Another way in which the federal government is active, and I think the healthcare reform bill will increase the federal government role, is in the area of healthcare delivery. So healthcare, of course, is delivered by private physicians, and it traditionally has been regulated at the state level by licensure and by tort law. But the federal government finances so much of healthcare. Nearly half of care now, Medicare alone, accounts for about 20% of the U.S. healthcare dollars that are spent. This money means that it's incredibly influential in the actual delivery of care, for better or for worse. In part, it exercises influence through mechanisms like its conditions of participation, rules that hospitals have to comply with in order to get Medicare funds. But that's not the only way that it exercises influence. And in particular, it creates new payment mechanisms that have incentives that influence the way that care is delivered in ways that can impact both quality and cost. So to give you one past example of how Medicare does this, at one point in time, Medicare was compensating hospitals based on their costs. So the hospitals would basically tell Medicare what their costs were, and then Medicare would write the check. You can imagine what influence this had on costs, right? Because there's really no incentive on the hospital's part to economize. What they did in the 1980s was they shifted to a new system where compensation of hospitals was based on the patient's diagnosis. And what this did is it gave the hospital an incentive to economize on the cost of treating a patient with a given diagnosis. And so this was a very dramatic change in the incentives facing hospitals. I think it did produce changes in behavior. And even more importantly than this, Medicare was a leader in this. It created this system, but after it was created, private payers, private insurers, many of them also started to use similar mechanisms in order to compensate providers. So that basically expanded the impact of these new kinds of mechanisms. This bill suggests that Medicare will continue to take a leadership role in various kinds of reforms that shift incentives within the healthcare industry. There are a few examples of this. For example, Medicare has increased the payment. The bill says that Medicare will increase the payment to primary care physicians to start to remedy some of the payment gaps between primary care physicians, who, relatively speaking, don't get paid very much, and specialists who get paid much more. It reduces Medicare payments to hospitals for certain kinds of hospital-acquired conditions, as well as penalizing hospitals for excessive readmissions. So one of the high costs facing Medicare is when people are discharged from the hospital and then they're readmitted to the hospital, and then Medicare pays again for that patient's diagnosis, and that makes it very expensive, and they would rather see the hospital do a better job of managing these patients so they don't need to be readmitted. It establishes a hospital value-based purchasing program where the idea is that you would pay hospitals more if they perform well on various measures of quality. which is not something that Medicare has traditionally done. They extend an existing program for quality reporting on physicians. And more generally, there are provisions in the bill to create processes for developing quality measures. They appropriated about $75 million specifically for the purposes of creating these measures. They put in provisions to extend or share Medicare data with other people so that they can develop quality measures. And the idea is that you can use these quality measures to try to increase healthcare quality. So you can look at some of these measures for hospitals today on the website. What the bill says is that they're also supposed to create a website for individual physicians. They've established a series of pilot programs, demonstration projects. One of them would involve bundled payments to all sorts of different kinds of providers. So now Medicare pays separately physicians and hospitals and labs and for outpatient services. What they want to do is they want to give one payment to all of these different providers and say, look, we want you to manage the care for our individual patients, and you collectively figured out the most efficient way to do that. And one of the specific forms of this would be what's called accountable care organizations that would be responsible for coordinating the care for individual Medicare beneficiaries. And what the bill says is that if an organization manages care in such a way that they meet quality thresholds but also save money, then those organizations get to share in some of that financial savings. And finally, the bill creates an innovation center within the Center for Medicare and Medicaid Services to do demonstration projects, basically tinkering with these payment structures to find ways to incentivize lower costs and quality. And so there are some provisions in the health reform bill that have the hope of improving efficiency, if not actually reducing costs. But I think a lot remains to be determined within the structure of regulation in the Medicare program and within the Department of Health and Human Services. But my broader point is simply that the bill does a lot more than just increase access, although that in itself is a huge thing. And it's an enormous amount is going to depend both on the new head of the Center for Medicare and Medicaid Services, as well as the specific regulations that are adopted that implements these programs. So should we questions?
Why don't we take questions, and then if there's time at the end, Ted Ruger, who was supposed to come, had a little car trouble, and he gave me his talking points about the constitutional challenge. To the extent we have time, I'll talk about that too. But if people have questions.
One of the elements that were used in trying to sell this bill was the fact it would actually lower costs to the government. At the same time, it was providing medical treatment to a whole lot of new people. And it didn't seem realistic to me. I've just heard that there are some savings, but is it realistic that we could actually save money and still provide medical service to a whole lot of new people?
No. I agree. I don't think that this bill is going to create a lot of savings. I mean, the bill is supposed to cost something like $1 trillion over 10 years. And it's financed through savings in Medicare and Medicaid, right? So just changes in the way the programs functions, including cuts to providers, right, and what they are paid. It's financed also through a variety of taxes, including taxes on the pharmaceutical industry, taxes on health insurers, and taxes on medical devices. So there's no real parts of this bill that are specifically directed at cost reduction. So I don't think that that one of the effects of the bill will be cost reduction. I think the reason why we don't have it is because people are not willing to do what it takes to get cost reduction, which is, I think, to get less care. I mean, in the best of all possible worlds, what we would get is research that shows what of the care provided today doesn't do very much. We know that a lot of the care provided today doesn't improve health, right? So we want to stop providing that care. We want to find new technologies that allow us to improve health for less costs. We want to be able to choose between technologies, choose technologies that you know, have lower costs than other technologies. This bill suggests that we will do research in these areas, but it doesn't ultimately say that we have to live with and comply with the results of that research. And so in that sense, I don't think this bill itself will reduce costs.
No, and I mean, it was politically impossible, because the minute that they, I mean, Sarah Palin got on the pages talking about death panels, I mean, all the things that we've given up on rationing healthcare in this country the way that we ration everything else, which is by people spending their money. The trend of the percentage of out-of-pocket payments in healthcare has been steadily down, and this bill isn't going to change that. So therefore we have to have some other way of rationing it other than by how people choose. And you know, we can't wish, and so some kind of utilitarian calculus is what economists think should happen, is what a lot of, you know, the market does that for us when people, you know, pay with their own money for soap and things like that, or for legal services. But we haven't done that for health. We've given up on that for healthcare. So until we have the political will to set up some mechanism for deciding what we're going to pay for and what not, then it's very difficult. I mean, there was the controversy over the mammographies that came up at the same time that the health bill was going through, and you know that there's pretty good evidence that from a utilitarian perspective, more mammograms are done than are necessary. But of course, if we don't do mammograms of women who are in that 40 to 50 age group, some of them will have breast cancer and will die as a result. And so the question of these choices, where we have identifiable victims and a collective payment system, is just very difficult. So I'm not.
Does that make it unconstitutional?
I don't think it makes it unconstitutional. I mean, the government makes. The government all the time puts itself in the business where there's hard choices and doesn't make them.
It's my understanding that Spain, which I think has a single-payer system, right now has a terrible cost containment problem, which is getting out of hand. And one of the things they're thinking about, I understand, is requiring some kind of a fixed co-payment every time a patient shows up for some kind of medical services. What would you think of that kind of idea?
Well, I think one of the things on one of the charts that Tom put up is that, in fact, healthcare costs are increasing in every developed country, probably every undeveloped country or less developed country in the world. But they're just increasing here faster, and they started higher to begin with. So it's not surprising to hear that Spain is struggling with this problem. Part of the issue, of course, is our expanding technology that is expensive, and yet people want to use it. In terms of the effects of co-payment, we know that placing co-payments, requiring people to make co-payments to pay something every time they use a service, does tend to decrease the use of services. But we also know that it doesn't always decrease the use of the right services, right? We would ideally like a co-payment to decrease services that aren't going to benefit the individual involved, but it also decreases services that really would benefit the individual involved. And also at this point, the levels of co-payments that exist are sufficiently low that they themselves don't raise enough money to really sort of shift costs from other payers to individuals. So I'm not sure that that's the answer.
Well, I don't think it was the thought of raising money, it's the thought of rationing service.
Right.
I mean, I would say that we tend to be ahead of the European, I mean, for better or worse, in terms of co-pays. Or that it's relatively new in European countries that there are these co-pays at all, and we have had them.
We have co-payments and co-insurance within Medicare. We have them within certainly all the private payers. They exist, and the only question would be, you know, do we increase them so that instead of paying, well, we have sort of increased them, I think, from, you know, $10 to $25, but do we increase them from $25 to $100? And if we do that, do we care about the fact that people are going to end up not getting care that they actually need?
I understand there was a fairly recent statute requiring parity between mental health and other kinds of health delivery. And I'm wondering whether this has any effect on that or how that plays into this reform.
Once 2014 happens, and then there is the Health and Human Services is setting what the basic plan has to be, then then we might, to the extent people think that that's a good, I tend to think that that parity is a good idea, although it's, the problem with mental health treatment is it is in some ways harder on average to know whether it's effective than for other kinds, although there's plenty of things. Think of low back pain, and you know, you can easily find a physical thing that's pretty hard to measure how effective it is. But I would say that the fact that the federal government is going to be setting what the basic plan is means that the significance of that, I think, will be less, although that doesn't kick in until 2014, and there's now litigation about whether insurance companies are complying with that.
Why was so much of the act delayed until 2014? Was that just political, or were there other good reasons for delaying the effective date of so much of the act?
I mean, I think it was political for sure, but I also think it's going to be hard. I mean, setting up these healthcare exchanges and putting in place in Health and Human Services the ability to do this regulation isn't going to take, you know, will take some time. So I think it's a combination of political. But my own view is it's more political than anything else. So.
And is the cost issue likely to be addressed during this time, or that?
No, I think we have to have a way more reading before we'll bite the bullet on that. I mean, that's just my own, you know, unfortunate view.
I once saw a presentation where they were looking at, you know, 40 or 50 year projections of increases in costs, and they said that, I can't remember what the year was, but eventually that the premiums for Medicare Part B would exceed the average Social Security payment to individuals. And the person presenting said, you know, this is just not possible. This would not happen, right? But what would happen to prevent that was much less clear. So at some point, we will say we can no longer handle spending so much money on healthcare. And at that point, we will have to decide how it is that we are going to try to ration costs. But until that day comes, I think we will just continue to push off the issue.
No, and there's some precedent that workers' compensation, which is insurance that pays for people when people are injured at work, started out being mostly about income replacement and just a teeny bit about health care. And about 10 years ago, it became more health insurance than income replacement, and soon it'll be 75% health insurance. And so it actually isn't not inconceivable to me that Medicare could cost more than retirement benefits, because with that population of injured workers, we're paying more in health care costs than income replacement. And that's what, you know, Social Security retirement is income replacement.
I don't understand your last comment that the time will come when we can no longer afford health care. The time may come when we can no longer afford a military establishment, or the time may come when we may no longer afford police or firemen. Isn't this a major discussion about values, what government should do? And I don't see any of that debated. It's all in terms of money and cost.
I think that's exactly right, and that's one of the statistics that you hear people talk about a lot in healthcare debates is the percentage of GDP that is spent on healthcare, and as if that's some inherently important number. And the fact is, it's not. Right? We spend a certain percentage of our GDP on potato chips, and we spend a certain percentage of our GDP on healthcare, and as you say, on police and all other services. The question is, how much do you want to spend? I think the issue is relative to other kinds of services, just the trajectory. That we are used to sort of this equilibrium where healthcare is now, what is that? We're now $1 trillion or whatever.
$2 trillion.
Yeah, so we're used to this equilibrium where healthcare is sort of a certain percentage of what we spend, and that percentage has been increasing very rapidly, and it's likely to continue to increase very rapidly. And that means if our income as a whole doesn't increase equally as rapidly, and we have no reason to think that it will, that something else is going to get lost. One of those other things is going to be cut down. And so I think what I'm saying is actually agreeing with you that really the question in the end is, do we want to continue to spend this much on healthcare? And if so, what else are we going to give up? Or are we going to give up some of our healthcare so that we can continue to spend on defense or can continue to spend on police?
You referred to the effect of this legislation on the donut hole in Part D. Is there any other aspect of Part D that is affected by this legislation?
Not that I know of, but there in a multiple thousand-page legislation, I don't know all the details.
That's probably an unfair question, but
Yeah, I'm not aware of it, but that doesn't mean it doesn't exist.
What's your view of the impact of medical malpractice litigation on the overall healthcare practice? Do you think it's significant or not?
It's not. In terms of actual liability insurance premiums and liability insurance premium equivalents for the self-insured component, we're talking somewhere around 2% of healthcare dollars. And the question so because that number is so small, what people will talk about is defensive medicine. And the problem with defensive medicine is that we don't have a good way of measuring it, because I teach torts, and when you think about what are the 3 reasons why we have torts. We have torts to compensate people, we have torts to, for retribution, and we have torts for deterrence. So at least retribution and deterrence are directed at changing behavior. So if the fear of liability changes behavior, we don't know whether that's good or bad unless we have a way of measuring what's good. And so at the end of the day, that's an area where President Obama changed, that in his early speeches, when he was talking about medical liability reform, he had the idea that it might change, that by addressing medical liability, we might be able to bend the cost curve. That's his phrase, which I like. But after he got educated on the subject, he stopped saying that, because it's wishful thinking to think that will change costs seriously. There might be other reasons to do medical liability reform, but healthcare costs isn't in my view one of them. And if you want to read the 200-page version of that, you can read The Medical Malpractice Myth, which is my book that came out.
We have time for one more question.
Talking about the Constitution.
Let me say, the basic concept. Let me give you the three points from Ted on the Constitution. The mandate that is that the challenge to the mandate is that it's not needed to, or that it's an interference in something that's not interstate commerce. And as Ted points out, and is really true, is that once you've got the elimination of pre-existing conditions, exclusions, then you have to have the mandate to make it work. And so the mandate is integral to making this economically feasible, which means that it's going to satisfy the constitutional requirements according to it. So that's his response on the mandate. And then there's a separate, independent, he claims, justification based on the taxing authority, because the way that these mandates are set up is as taxing. And the government has lots of power to tax and spend. And then there's some concern that there's a 10th Amendment violation because of the requirement that the states do certain things. And Ted's analysis is that the federal government does lots of things that, in effect, coerce the states into going along, and then he thinks there's not much to that too. But I would say the response to the mandate is that you can't do it without mandating, and the government certainly has the power to have its own public provision. Or so we could have single payer. We could have Medicare for all, and the only way to have equivalent coverage for all when you're going to be eliminating pre-existing condition exclusion is to mandate it. So with that, we have to stop because there's the next round, the next hour of CLE credit is coming up.
Thank you very much.